case in this challenge. It's the case number 20, and you've got, this is a case that was at 27 weeks, and this is a case that you had the color, and that gives you a bit of a clue, is it? And also it's showing only, I think Hyman did, when he showed this case, he showed, oh, this is mainly looking for the vessels, so the 3-vessel trachea view. So you've seen the 3-vessel here. And if you go a little bit higher, and this is the key plane that you can see the abnormality. So what you see in this plane? So you're seeing obviously the color, and you see the structure in the middle is the trachea, and you're seeing another blood vessel that's crossing behind the trachea, and usually it crosses from the left to the right, and it shouldn't be, there should not be a vessel crossing behind the trachea from the left to the right. So, and therefore, this is apparent right subclavian artery, which you can say is potentially maybe a normal variant because it's present in some babies or some fetuses that are normal. And it does not necessarily cause obstruction traditionally. Not like, for example, if you have double aortic arch or right-sided aortic arch, which might have some pressure effects. ARSA does not. But the key thing, so the abnormal, or actually anatomical variant. And again, let's give you a clue, is it? Because all the case that you had was normal, abnormal. This is the only case that you had normal and anatomic variant. So even if you didn't know anything, sort of just by guessing or sort of, saying, well, that's a bit unusual to have anatomic variant, that's the correct diagnosis. And then you had the right aortic arch, no, that you couldn't really see anything right aortic arch there. Double aortic arch, no. Is it apparent right subclavian artery? That was a correct diagnosis. And I think the key really thing that when you have the apparent right subclavian artery, apart from actually looking at the heart in details and looking for cardiac abnormalities or extracardiac abnormalities, it's association with genetic abnormalities or chromosomal abnormalities, in particular, of course, trisomy 21 and DiGeorge. Therefore, in this case, you would see if the patient had self-18A, did you have screening, would you sort of discuss the risk and offer invasive testing. So 91% of you got it right. That was anatomic variant. And again, 83% of you got the diagnosis right, which is ARSA. So any other comments, Katia, on this diagnosis?
Well, my comment is that, in my opinion, there has been a large study from Italy that has shown that if there are no other anomalies present, because we think especially of Down syndrome, and if we don't see any other signs that are suspect, the chance of an association with the chromosomal anomaly can be considered quite low. And so maybe this is exactly the case where an IPT, cell-free fetal DNA, could be of use.
Yeah. And but also I think, my own view, and I think it's interesting to how to apply it in different countries, that nowadays with the wide use of cell-free DNA, particularly in certain countries like the Netherlands where you work, where a lot of patients already have cell-free DNA in the first trimester, to some extent, you already know a lot of babies who have Down syndrome. So, and therefore, the one that get to the second trimester and you have, for example, ARSA, to some extent, you ruled out already Down syndrome. And that might be different in maybe another healthcare system where you don't have the wide easy access to cell-free DNA in the first trimester. So, and therefore, I think it's this genetic testing and the association, I think, just from the research point of view and epidemiological point of view, it also depends on what's the background risk of this population. And if you already had the population with first trimester cell-free DNA, I suspect that the incidence of undiagnosed Down syndrome in the second trimester is probably very low.